Hello, my name is Petra Lewis. The core objective of this short lecture is for you to be able to learn how to interpret breast MRI scans using the 2013 ACR BI-RADS lexicon. In this talk, I'm going to be focusing on gadolinium enhanced breast MRI, although just note that the ACR BI-RADS does include a section on implant assessment. The ACR BI-RADS was developed for breast MRI in 2003 to be able to provide a uniform interpretation terminology for radiologists who are reading breast MR, but it was updated in 2013, and throughout this talk I've highlighted in yellow the changes between the 2013 and the 2003 terminology. It didn't actually come out till 2014. Similar to mammography, your end assessment category will be a BI-RADS 0 through 6, and these are identical to the mammographic ones, so I'm not going to repeat them here. The report structure is going to be somewhat similar to any other modality that we're interpreting in radiology, so it will include the indication, the technique, the composition of the breast, and this is going to include both the amount of breast parenchyma present as well as the background parenchymal enhancement, as I'll talk about in a minute. And then for all findings, the morphology, the distribution, the kinetics, and the T2 signal, the presence or absence of any comparisons and any changes, as well as a final assessment and management category. It's important to include in your indication a couple of things which will affect both the interpretation of your findings as well as any follow-up imaging, and those include personal family history of breast cancer, the presence or absence of any personal or family genetic syndromes such as BRCA or Cowden's, any clinical findings or symptoms, whether the patient has undergone any prior breast surgery, radiotherapy or chemotherapy, if they are premenstrual, what stage they are in the menstrual cycle, and whether they are on any hormonal therapy whatsoever. So let's start with the amount of fibroglandular tissue, and this is a new category that came in with the 2013 criteria, and these are identical to those from the mammographic literature in terms of their categories. Note that there are no percentiles attached to this. So I'm just going to give you some examples here of what we might classify as fatty, scattered, heterogeneous, or extreme fibroglandular density. Now, do remember, however, that the difference between an MR and the mammogram is that you do need to scan through all the slices to get a real idea of the 3D volume of these tissues. I find that either using the fat-suppressed T1 pregadolinium or the non-fat suppressed T1 images are most helpful for this, but I often go back and I look at the mammogram as well and just make sure that I'm being consistent between the two. The next thing that you need to note on all scans is the background parenchymal enhancement, and this goes into 4 different categories: none or minimal, mild, moderate, and severe enhancement. And this is the enhancement of the fibroglandular elements, so not the fat. So you only need to look at the fibroglandular elements for this. You also need to note whether it's symmetric or asymmetric. So let me just show you some examples here. So the images on the left here are going to be the gadolinium enhanced fat suppressed images, and the ones on the right are going to be the subtraction images. So this first image pair on the top, the patient has probably a fairly extreme or at least heterogeneous fibroglandular density. However, they have virtually no enhancement. The next image down here, the patient has heterogeneous or scattered. You'd need to look at the whole volume to tell, and only mild sort of punctate enhancement in there. In both of these images, the patient has heterogeneous density, and on the top, moderate, and then on the bottom, severe background parenchyma enhancement. You can see with an image here, this is definitely going to significantly impair your identification of small areas of malignancy. I actually quite like looking at the MIPS. I find these are the subtraction MIPS are a really nice way to get an idea of the background parenchymal enhancement in the patient. You can also get a much better idea of the symmetry. But just, to remind you, you do need to look at the amount of fibroglandular tissue there to make the full assessment. As I said before, you do need to note whether the background parenchymal enhancement is symmetric or asymmetric. This is a patient who has very asymmetric enhancement. The reason in this case is because her left breast had prior lumpectomy for malignancy and radiation treatment, which tends to decrease the background parenchymal enhancement. In a case where there is asymmetric enhancement like this, you categorize it by the breast that has the most intense degree of enhancement. So in this case, it would be probably at least moderate. If the patient has undergone breast augmentation surgery, you need to identify that, and then you need to say what type of implants they are, silicone or saline, and if they have more than one lumen. Now, for every lesion that you identify, there are a number of things that we need to note. First of all, you need to note what side it is, obviously, how big it is, what quadrant it's in, or whether it's retroareolar or deep central, and what clock face it's in. The reason we include both of those is it's not infrequent that the radiologists misstate the clock face while they're getting the quadrant right, so it's a little double check there, and also the distance in the nipple. With the 2013 MR BiRADS, only 3 lesions or 3 lesion types are described. It can be a focus, a mass, or non-mass enhancement, or NME. Non-mass enhancement is what we used to call non-mass-like enhancement previously, and they've also removed the category of multiple foci. I kind of like this image to help differentiate between these 3 different categories. So, here's your picture of the galaxy, and these individual stars out here, well, they're kind of like foci. You can't describe them as anything other than little bright spots on the background. A mass has 3-dimensional characteristics, so it's more like a planet. And this kind of fluffy, smudgy stuff that really doesn't have 3-dimensional characteristics is the equivalent here of a nebula, and it's a non-mass enhancement. So let's start with focus. So a focus is basically, a little dot. It's usually smaller than 5 millimeters or 5 millimeters and smaller, and you can't really clearly define it as either a mass or non-mass enhancement, but it stands out from the background parenchymal enhancement. You don't want to call every little dot of BPE a focus. And in this case, you need to describe the size and the kinetics. So here's an example of a focus here. It stands out from the rest of the parenchymal enhancement, which is pretty minimal. Masses, on the other hand, have several distinguishing characteristics. You need to define their shape, the margins of the mass, the enhancement pattern of the mass, as well as the kinetics. I'm going to do kinetics right at the end. So the shape of the mass can be round or oval, which includes lobulated, or irregular, and they removed the separate category of lobulated because they didn't find it was helpful, and they've removed stellate as they didn't feel that could easily be distinguished from irregular. So here is something that's clearly round. It was a lymph node in this case. And these 2 masses can be described as ovule or lobulated. These are both cancers. Irregular masses tend to have angulated borders rather than the smooth borders of the oval/lobulated masses, such as these. Both of these are invasive ductal carcinomas. The margins of the mass need to be described next. These can either be circumscribed or not circumscribed, and the non-circumscribed masses may either have irregular or spiculated borders. To be honest, I'm not entirely sure why they differentiate between these 2. So this is a oval mass with circumscribed borders. This is a fibroadenoma. On the other hand, this is a oval/lobulated mass that has irregular borders, so it has little fine spicules that we can see here. Well, this cancer has has not circumscribed borders, which are defined as spiculated. So when does something that's irregular become spiculated? There's no definite definition, but I use as, when some of these little pointy bits coming out are as big or bigger than the mass itself, I start to call it spiculated. The enhancement pattern of the mass falls into 4 categories: homogeneous, heterogeneous, rim enhancing, or non-enhancing dark septa. And they have done away with these 2 categories, central and enhancing septae, in the 2013 criteria. And that's because it was really difficult to sort of distinguish between non-enhancing dark septae and enhancing septae, because it's kind of like, does a zebra have black stripes on a white horse or white stripes on the black horse? So this is a little metastatic node that has homogeneous enhancement. This invasive ductal carcinoma is lobular in shape, circumscribed borders, but has heterogeneous enhancement. This lobulated mass with circumscribed borders has rim enhancement. And then finally, this oval mass with circumscribed borders, the fibroadenoma we saw before, has dark non-enhancing septae within it, which is a fairly pathognomonic finding for fibroadenomas when you see it. All right, so moving on from masses to non-mass enhancement. Well, non-mass enhancement is something that's bigger than 5 millimeters, but it's not a mass, so it doesn't have those clear 3-dimensional convex characteristics. It can be a very variable size, but the important thing is it's discrete from the surrounding parenchyma, because otherwise it's going to be background parenchymal enhancement. We need to describe 3 things with non-mass enhancement: its distribution within the breast, its internal enhancement characteristics, and then again the kinetics. You see that kinetics are consistent across all 3 different types of abnormality. The 2013 criteria got rid of a couple of distribution modifiers, and now we're left with focal, linear, segmental, regional, multiple regions, and diffuse. They got rid of ductal because it was difficult to distinguish ductal from linear, and they got rid of dendritic reticular, which is good because I never knew what that was. So here's an example of focal enhancement. It's bigger than 5 millimeters, but it isn't as big as a segment. This is an example of linear enhancement. You might see this on the sagittal or on the transaxial images. And this is being defined as being segmental enhancement because it is a triangle with a narrow end towards a nipple, or a pyramid if you look at it 3-dimensionally. So it's filling a ductal distribution. This is greater than 1 ductal distribution, but it's contiguous, so it's called regional. But in this case, there are multiple regions which are non-contiguous. And then in this patient, this is diffuse non-mass enhancement. And this has to be distinguished from just intense background parenchyma enhancement, often because of the asymmetry, but that can be, sometimes a tough call. And this, in fact, was diffuse DCIS. So we need to describe, after the distribution, the internal enhancement characteristics of non-mass enhancement. And these are 4: homogeneous, heterogeneous, clumped, and clustered ring, which is a new one, and they got rid of stippled. So this patient has a focus, because it doesn't really fall into a segment, it's not big enough to be a region, of homogeneous enhancement. This, however, has multiple regions of heterogeneous enhancement. This is clumped enhancement on the 3D images, the whole set of images. It was actually in a segmental distribution. And sometimes it's hard to understand what we mean by clumps. I kind of think of it almost like a microscopic slide of clumps or rouleau of red blood cells. So you get sort of bits a little bit smaller, more discrete, and bigger clumps together, but it's not continuous. The enhancement modifier that was added in 2013 was clustered ring, and this is a good example of clustered ring. It has a very high predictive value for DCIS. And you can see all these little separate rings here that form this pattern. I think of this as almost, it's like a crazy paving sort of pattern. And it's kind of like the breast equivalent of the pattern you see on CT for alveolar proteinosis. I'm just going to move on finally to kinetics, and I'm not going to spend a lot of time on this. Most institutions will have some form of kinetic analysis software, or it's really computer-assisted detection that allows you to look at the kinetics of gadolinium as it flows into and out of the breast. Here's one example. There are two things that we describe about the kinetics. The first is the intensity. So does it at the first time point of imaging, at the peak time point, increase to 50% over baseline or 100% or more over baseline? And then we describe the initial upslope, whether it's slow, medium, or fast, and then the delayed phase, whether it's persistent, plateau, or washout, which I'll show you in just a minute. And this is really the key finding here, along with the intensity. So if you put these parameters together, with scan 1 being pre-gadolinium and scan 2 being at peak, then we divide the curve into 3 different appearances. So first of all, the type 1 curve, or the blue curve here, is the curve that continues to increase during the multiple phases of the examination. The type 2 curve here in yellow comes up to a peak. And generally speaking, we're going to be, depending on where you set your criteria, you're going to be greater than 50%, but you could be as high as 100% above baseline. And then it stays pretty much the same. So it doesn't change to the end of the scan more than 10% plus or minus from that peak value. And then finally, the washout type curve, or type 3, is it increases rapidly to peak, and then it decreases the latter part of exam more than 10% from its peak value, and that is the highest predictor for malignancy. So just to give you a brief idea of how one categorizes these different kinetic curves. If you see a lesion, you should identify whether the T2 signal in it is decreased or increased. If the patient has had prior breast MRs, you want to say whether it is stable or not from that time. And then finally, you want to mention if there are any other concerning findings. And I'm listing a whole lot here, but whether the nipple is involved or retracted, whether there is any skin invasion or retraction, the presence or absence of axillary adenopathy, and we always describe how many nodes appear abnormal and what size they are, whether there is chest wall invasion or pectoralis muscle invasion. To have chest wall invasion, it's got to go through pectoralis to the other side. If the patient has high signal in the ducts, which we see with secretions in ductal ectasia, whether there are simple or more complicated cysts, whether there's a hematoma or seroma or edema in the breast. You may see masses that are non-enhancing. You may see dilated ducts that contain simple fluid. Skin thickening can be present from a large number of reasons, including post-therapy changes, and whether there is any architectural distortion. Sometimes you can see the architectural distortion best on the non-fat-satted pre-gadolinium images. And then finally, whether any signal voids and clips and their relationship to any mass that you are describing. Fat-containing lesions in the breast are benign, so it's always good to look at the pre-fat-satted images to confirm this. If there's a lymph node, whether it's abnormal or normal, whether it's fat necrosis, whether there's a hamartoma or a post-operative seromas that contain fat. And these fat-containing lesions are a new category in the 2013 lexicon. And then, as I said, similar to mammography, you need to come up with a final BI-RADS category, 0 to 6. and you need to decide what management is appropriate for this patient. This might be follow-up, it might be going on to have a callback ultrasound, it might be surgical treatment, and so on. Just to note that generally speaking, from a breast MR, you should only use BI-RADS 0 if you feel that additional imaging might downgrade that patient to a BI-RADS 2, or if you feel that there's a technical issue and that you're going to repeat that study. You should not be using BI-RADS 0 for lesions that should be biopsied regardless of a negative callback ultrasound, for example. Okay, I hope that's given you some kind of a guidance on how to implement the ACR BiRADS 2013 criteria in your interpretation of breast MR studies. Thanks for listening.